See You Now is a podcast highlighting the innovative and human-centered solutions that nurses are coming up with to solve for today's most challenging healthcare problems. Created in collaboration with Johnson & Johnson and the American Nurses Association, and hosted by nurse economist and health tech specialist Shauna Butler.
How can people not have access to care? Maybe they have access to care, but maybe the type of care that they're being given is not the type of care that people deserve. Giving vaccinations, educating people, knowing their families, and being able to say to them, do you have food for your family? Do you have heat? Are you okay with clothing? Those are questions I ask of my patients every day. They're not a sinus infection. They are a person who's there to seek care.
Welcome to See You Now. I'm Shauna Butler. Access to care. 3 very simple words, and yet 3 very loaded words that we hear a lot. They're uttered with such frequency and roll so easily off the tongue that their pivotal role goes underappreciated. Throughout the pandemic, and especially with COVID testing, and more recently with the rollout of the COVID-19 vaccines and the frenzied hunt for an appointment to get one, many are experiencing just how significant and important access to care is. And why are people struggling with access to health care? It's a big question and an even bigger problem, and one with serious, life-altering, and often life-threatening consequences. Despite there being vast healthcare resources, for many people, access to care is frustratingly difficult and frequently includes long wait times. And too often, the care that people are able to access doesn't really meet their needs. In this episode, we zoom into New Hampshire, where nurse practitioner Wendy Wright examines access to care and explains her refreshing approach and different model for primary care, where access includes time, presence, data, outreach, and an appetite for innovation to meet people where they are, even if that's online, in a car, under a tent, or in a parking lot.
I'm Dr. Wendy Wright. I am an adult and family nurse practitioner and the owner of Wright and Associates Family Healthcare, located in Amherst and Concord, New Hampshire. I've been a nurse practitioner now for 29 years, and for the first 12 or so years worked alongside a physician. And for the last 15, 16 years, I have owned 2 full-service primary care clinics.
One of the areas that I want to spend some time talking with you about is access to care. We hear that phrase a lot, and I'm not sure when we use the concept of access to care, if people really have a broad enough understanding. And the area where I think that you've been pretty focused on is making care available to more people. And I don't know that there is an understanding of just how hard it is in a place like the United States with hundreds of thousands of care providers and remarkable health facilities and technologies and all of these things that we have, why it is that people still have trouble getting care. So I want to open that up to you and you share what access to care is for you.
You really hit the nail right on the head. How can we in the United States, how can people not have access to care? I have a thought about that. One is maybe they have access to care, but maybe the type of care that they're being given is not the type of care that people deserve. And that really was my reason for leaving the job that I thought I would grow old in. It was a perfect job for me. I was working alongside a physician. I was in a family practice in my community. I was job sharing with an amazing nurse practitioner colleague, but it just wasn't right. And what wasn't right was I was being asked to see and do more things and to not be able to devote the time with these patients. And it's not just about time. It's utilizing that time. And I felt like I wasn't true to myself and that I was going home every night, not able to put my head on a pillow. And it always felt like to me, if I can't do that, it's time to really make a change. And so I left my practice after all those years. And long story short, here we are. And I have opened these clinics firmly believing that people are not going to be treated as numbers. We're going to know who they are. They're not a sinus infection. They are a person who's there to seek care. But the care that we give them is not going to be just about what they seek care for, but it's going to be the things that we also know we need to do. Preventive care, giving vaccinations, educating people, knowing their families, and being able to say to them, do you have food for your family? Do you have heat? And are you okay with clothing? Those are questions I ask of my patients every day. And I don't necessarily think that that's being done. So that was my first clinic. We went from 7 patients to 4,500 patients over the last 13 years. Now, my Concord office is a different story, and I think this is fascinating. Concord is the capital of New Hampshire. You would think that there would be a plethora of primary care providers in that city. It's where our government is. But I will tell you, when I opened Concord, there was not one primary care clinic in the capital of New Hampshire taking on new patients. You had to put your name on a waiting list, and you had to wait until someone left the clinic, and then they would call you once your time came up. So people were waiting months, if not up to a year, to get primary care. And I knew that that hole existed because I had people drive 25 miles to my Amherst clinic to get care because they couldn't get it anywhere north of where we were. So that's what access looks like to me. It's not just being able to get in front of someone, but it's being able to get in front of a provider who truly is invested in your care and wants to partner with you.
Yeah, that's another really interesting dimension that you bring up about access, which is presence. That's really a dimension that I don't think we spend much time talking about. So you hit on something really important when you were talking about your primary care practice. When you started this, what are the core values, of your practice? When you go about delivering care, what is that vision of your practice?
That vision is from the person that checks you in at that front desk to the medical assistant that puts you into the room, to the nurse practitioner who takes care of you, to the person who does your billing and the IT person. You to us are a human being deserving care. Whether you have $1 to your name or you are a multimillionaire, we are going to provide you with the care and level of service that I want for me and I want for my family. And that was so essential to me. We're going to take care of you. You are a person. And I always tell my team, when we forget that these are people with lives, we've forgotten the whole reason we opened this clinic. Not to be another access to care, but to be a different model of care.
Different model. Let's talk about that. So what's the current model? I mean, for most people who are going to a primary care practice, let's start out with what their experience is looking like if you're 50 years old and you need to go for a colonoscopy or any one of these preventive services where primary care is the place where you would go get that. What's that typical model and experience?
Right. So it starts out with, if you are new to me, you're going to have an hour of our time, not an hour with the medical assistant, but an hour with the nurse practitioner. We're going to take all of your history. We're going to build that chart so we know you. And people will say, I have never, ever spent this amount of time with a provider, ever. And then what happens is we identify all those needs of the things you have, and my team goes about booking those appointments along with you. Now, some of the specialists will fax over a referral and they'll take over and they will call the patient, but we go one step further. We set a reminder for a month later. And if we don't have that colonoscopy, we're going to call up the patient and say, we don't have your colonoscopy. Have you gone? And if you haven't, is there anything we can do to make this happen? So that type of detail, that type of follow-up, we also care plan a visit. Every patient who walks through our door, we care plan that chart. And what that means is we look ahead. We know when you walk in or a patient walks into our office that they need a tetanus shot, or that they're due for a mammogram, or that they're due for a pap smear, so that we have 4 eyes looking at that chart so that we can optimize the time we have with people, because we know people don't want to be in with us. Many people don't want to come to see us. And we know that that's our one chance. And if we don't capitalize on those opportunities, so many of the things, the preventive care that really, I think, keeps people healthy and picks up disease early, which is so essential, I think that that is critical to keeping people well. So that's what a visit would look like. And that's how we would get you to go for those tests. And we'll talk about it at every visit. What can I do to get you to think about the colonoscopy? Well, if you're not going to do that, can we maybe get a Cologuard on you? Because something's better than nothing. Let me meet you where you're at. Let me tell you why it's really important, because I never want anyone to come back and say, you didn't tell me.
The luxury of time. I think that that is what we're all really craving. And your invitation to a patient, is there anything we can do to make this happen? You have had a moment in time with COVID and the pandemic where that's more than just a rhetorical question. What have you done at this moment in time where we've seen across the country, primary care practices have not been able to meet people where they are? Many of them, because they're small businesses like any other business, they've had to close.
I'll tell you, Shauna, I was scared. When March of last year hit, I looked at my business, and within a couple of weeks of all of the discussion on COVID, I saw that our visits were down by 50 to 60%. And I was scared. This is my livelihood. This is what I've invested my entire career in. And I also looked and thought, I've got 24 women who are counting on me to figure this all out. What we did was we met people where they were at. We said, okay, we are going to see you, but we're going to call you all the day before. We're going to make sure you don't have any symptoms remotely connected to COVID. We're going to clean our waiting rooms every hour. And I communicated that message to my patients every week on the portal. I posted it on social media, letting them know what we were doing to keep them safe. What we also did was I said, I need a tent in the parking lot. I need to be able to screen people for COVID. I need to be able to see sick people, but not bring them into the office to expose my team. It's kind of evolved over the last year, but I'm proud to tell you I love that tent. We are out there every single day, 60 minutes to 2 hours, rain, sleet, shining, heat, you name it, we're out there. And we are seeing people in their cars. We're giving them flu shots because they're too scared to come in. We're drawing their blood. We're screening them for COVID. We have spirometry out there so I can do a breathing test on them that we don't want to do in the office for fear of spreading COVID-19. We've done 2,500 acute visits out there, and my team has been amazing. They don't complain. They do it, even though it's really hard. The luxuries of the things we're so used to in a clinic, they're just not there when you're outside doing an abdominal exam in someone's car. But it works, and you would be amazed at some of the things that these NPs have picked up. And every day when we're out there doing the tent, people bring us cookies, and they bring us notes, and they bring us food, and they're just so grateful. And I think we're better today than we were 2 years ago financially, because those visits have really sustained us. We're lean with our staff. I did furlough 7 during COVID, but I was lucky enough to get the PPP money, and I used it for exactly what it was designed for, to be able to pay my team, to be able to bring them back in. I just really didn't know what the future looked like for us, but I'm happy to report we're doing well, and we've stayed open. We haven't closed one day since this pandemic hit, and that's very different. One of the latest statistics I saw is that 60,000 primary care providers have actually shut down.
Yeah. It's interesting having this conversation because there are 2 lenses that you are having to view the situation through. One is as the business owner, as the employer, as the resource to the community, what do I need to do to be financially viable so that I can offer these services to the community? Then there's the other lens, which is I'm the clinical provider. There are people out there who need these services, and I need to keep them safe, and I need to keep my team safe. So it's that dual management of these simultaneous challenges. And it is unique to the US that we are seeing primary care practices close, providers retire early. We're seeing a challenge because those primary care practices are also, they're training grounds for our next crop of providers. Let's talk about the innovations or how we're solving actually delivering care. So this summer, I was part of some of these pop-up drive-through clinics. You're outside, you don't have electricity, you don't have running water, and you got people driving through in any number, shapes, and sizes of cars. You're doing the full range of care, an abdominal exam, throat exam, ear, nose, and throat. What are some of the things that you've had to do? Because like you said, you're outside. You don't have all of the equipment that you're so accustomed to using. What if you had to rethink what things are you taking care of in a parking lot?
Right. So it's been so amazing. I mean, you take so for granted simple things like being able to lay someone down and do obturator and psoas signs on patients to look for an appendicitis. You take a nebulizer for granted. You take a chest x-ray. During the height of the pandemic, no one would allow patients in to get a chest x-ray. They would tell us, keep your patients out of the emergency room. Do not send them unless they are dying. I felt like we were the only thing that stood between these people and their death because we're sending them home with O2 sats. Shauna, I'll never forget. I told a patient, I can't get you an incentive spirometry, but here's what I can do. I want you to go to the drive up at the pharmacy. I want you to ask them to go to their aisle and pull you a bag of balloons. I want you to blow up 5 balloons a day. And I said, this is an incentive spirometer. This is what the hospital would have charged you $100 for. It's $2 at the pharmacy. And people would do it. And I said to them, that's how you're going to open up those lungs. So we've seen everything from not just in our parking lot, but I had a woman through telehealth, scared to death, would not come over to our clinic, nothing, but was willing to do telehealth. Her only presenting complaint was, I get this really funny smell. It lasts 10 minutes. I'm the only one that can smell it. And I knew it was an olfactory hallucination. I knew she was either having a seizure, unusual to be a migraine at 70 plus, or I thought she's having a brain tumor. We had to move heaven and earth, but I was finally able to get her a CT a day later. And it was a huge glioblastoma with so much edema that she was having a shift in her ventricles. They direct admitted her and she died within 3 months. And so I think that what we did was we gave people a place that they could come. They knew that they were safe and they knew that they weren't alone. And I don't know if you saw this in your experience in Texas this summer, but a lot of the specialists, the hospitals said, we're closing all operations. The only thing we're doing are emergency surgeries and hospital care. Specialists, you need to close down. All these patients who rely on specialists for their medicines, their seizure drugs, their cardiac drugs, they couldn't get in touch with anyone. We were their lifeline. And we continue to be, because now they can't find another specialist because their specialist retired. I'm proud of the fact that my team said, you know what, we will meet you wherever. If we have to drive to your house, which we've done, to drop off medicine, we'll put it in your mailbox. We've done that. We've collected food for our patients who didn't have food at Thanksgiving and put together baskets and put them out on the benches in the front of our office so that they didn't have to come into the clinic. So we've picked up some really cool stuff. We've done some really good work, and I'm so proud of my team.
Because we had so many practices close, we've had screenings that haven't been done. We've had people who were scheduled to have some type of a diagnostic where we know a cancer might have progressed, a cardiovascular disease might have progressed, any of these other conditions. I guess just from the standpoint of the acuity of the people that you're seeing, Wendy, I'm worried, and I think you've set off a lot more alarm bells because we have delayed so much of what would have been surveillance, detection, preventive care. What are we looking at in terms of the overall health. I mean, I just saw last week the average length of life has decreased by a full year, and even more so with people of color. So what are we about to see, and what do we need to do?
Right. By July 2020, some statistics were released. So we were just 3 or 4 months into the pandemic, that our Medicare beneficiary visits were down by 50%. Some of the nation's most vulnerable, those most at risk for COVID, and their visits were down by 50%. Well, you think, okay, well, that's all well and good, right? Because we don't want them in the office. But the problem is they also have a multitude of chronic illnesses like diabetes, like hypertension, that was not getting addressed. It was estimated that 80,000 cancer diagnoses had been delayed or missed due to the surgery issue. There was a study that came out not that long ago, and what they basically said is that people today are still saying that they really do not feel like getting care is something that they ought to be doing. 25% of survey responders, this was a study that came out in January, 25% said it is unwise to seek medical care right now. And the highest rates were in people of color. So this is a real issue. What people are predicting is that this delay in care is going to add up to 8 to 9% in cost into our already overburdened healthcare system, not to just mention the workload. I'm telling you that the visits that we are doing in our clinic right now are hard. They're really hard because people are trying to make up for lost time. They come in with lists of 10 and 11 items. Plus, we've got all the things that have already been delayed, and they are not seeing their specialists. They haven't been back for their cardiology visits or their pulmonology. And so we're trying to take care of all of those needs. Then you add on the mental health issues.
Yeah, let's talk about that.
40% of our diagnoses prior to COVID were already mental health to begin with. We were already dealing with lots of mental health issues, the depression and anxiety. But I will tell you that probably 1 out of every 5 people doesn't report a mental health issue with me, but 4 out of 5 do. I think that the numbers regarding mental health are just compounding an already overworked, tough system to begin with.
Before the pandemic, we already had health systems that were under enormous amounts of stress. There were enormous amounts of primary health care needs that were not being addressed. Again, going back to that access issue. As an innovator, as somebody who's always been thinking about how do we solve this problem, how are you innovating on the primary care side as far as helping us work through a lot of demand issues? So many people who need care. What are you doing?
So a couple of things. One is I'm training the next generation of nurse practitioners. I've been precepting for the last 3 semesters, even with COVID. So we're bringing them in and we're training the next generation because what we're seeing is that there's a cog in the wheel academically because people couldn't get placements. So people are delaying their graduation. People are retiring at huge numbers. And we're having this huge gap in people having to wait months to get access to care. So I'm precepting, I'm training the next generation, and I just signed on to be the COO of a company called America's Nurses. And we just opened up our first primary care clinic in Nashua, New Hampshire, led by NPs. And we know that Nashua is really a primary care shortage area, particularly for people of color. And so we really are going to be opening up clinics around this nation that are going to be NP-led care in communities that are in need of care.
So you've been spending a lot of time gathering data to help us really understand where the clinical value, the economic value, the health value, how that plays out in primary care. What data are you collecting and what is it telling us?
I've always been a data junkie, but I've always believed, and probably it's because I was one of those NPs that came out of school when there were only 25,000 of us. And my professor said, you must document the work you are doing. You must contribute to the body of the literature. And so I live that. And so I partner with 2 academic institutions. Every year, they give me 1 or 2 cohorts of either master's or doctoral students. And I, along with those students, choose a project or some type of disease state that I feel like we're not doing a great job at managing. And so we work on this together, and their faculty works on it, and they come in and they spend a year looking at guidelines, data mining what we're doing, and then presenting that back to all 9 of the NPs that work alongside me and saying, this is where you're at. This is where we see improvement. And then we publish it. And I think it's imperative that we publish it. I look at you as a person. I try to incorporate all of you and your family and everything about you into the care that I give you. I demand in my clinics that we look at what we're doing, because at the end of the day, people always say to me, when I did my doctoral work, I went into NP clinics and I said, what do you think your vaccination rates are for your patients 65 and older on these 6 vaccines? And the NPs were like, they're awesome. I said, well, give me a percentage, 60, 70%. Well, I data mined for them, and I looked at thousands of patients, and their numbers were 10 and 20%. So if you're not running your reports and you're not looking at your data, you think you're a heck of a lot better than you are. Now, you might be really good at the care you give to the people that come through your door. But what about the people who don't come through your door? Because no one's bothered to reach out to those patients. So earlier, Shauna, you asked me, well, what are you doing now? We're running reports, and we run them every month of people we haven't seen in the last 1 year. And we personally reach out to them. We see you haven't been in. What can we do to give you some care? And we do everything we can to try to get them into the office, because we're only as good as if they're in front of us. We're also doing telehealth now as well, which right now is about 15, maybe 20% of our visits. During the pandemic, it was 60%. But I'm lucky I'm in a state where telehealth is paid at parity with an in-house visit. And that really enables us to be able to financially continue to offer a service that many people really love. And it works well for those patients.
And you have a very strong philosophy about prevention, and from the standpoint of why these things are falling through the cracks. Why are people sicker now with all of the great advances that we've had within healthcare, within medicine, within drug trials, and everything that we have done as far as discovery and surveillance and treatments? What is that missing link between prevention and having better care, despite the fact that we've made so many advances?
You know that this country has invested in the latest, greatest CT and MRI, the latest intervention. What this country hasn't invested in is primary care. And look at it now with COVID. In my state, in order to get certified for a vaccine, you need your primary care provider. They gave us 3 days to data mine your chart and find 2 qualified conditions. And if your primary care provider doesn't submit them to the state, you don't get a vaccine. Well, you know what? We did it. My team, I told them what we were up against, and the NP said, give me names. Tell me what you need me to do. We will certify. We did 6,000 patients. Every NP took 500 people and said, our patients are going to be certified because we want them to have this vaccine. But think about people who don't have primary care providers who are willing to do that. My team said, I'll do it after work every night. And that's what they did. Every night for 3 nights, the NP signed in and data mined so we can certify our patients. But there are people who don't have access to care. And unfortunately, these people who maybe have no health insurance, if they don't have an established relationship with a primary care provider, they're not becoming certified. And that is just really heartbreaking. So I am the nurse practitioner representative to the state of New Hampshire Immunization Advisory Board. So I've been very integral in the vaccine care in our state. But as of today, the state is controlling all the distribution of the vaccine. They've set up 15 sites around the state. It is staffed by our National Guard, retired doctors and nurses and NPs. And you make an appointment at one of the state sites. You drive up in your car, you wait in your car, you get your vaccine, and you wait for 15 or 30 minutes and you're done. So once you get there, the system is done really, really well. But I do have a lot of patients who have said to me, I'm so sad I'm holding out because I want you to be the one to give me my shot because you know me. And I want you to watch me after that shot is over. And I say to them, don't wait. Please don't wait. New Hampshire is what we call a universal access state, which means I am given all the vaccines for every child in the state of New Hampshire. So you can get vaccinated anywhere if you are a child between 0 and 19 years of age without any cost to you, and the state provides all those vaccines. Now, we don't have that same model for adults. We have to purchase our adult vaccines, but for the COVID vaccine, there's no cost to it. And so I know that once we get it, we'll really be able to ramp up and get our patients vaccinated.
So since you brought it up, vaccines with children, this has been one of the other casualties of COVID.
Absolutely.
And then also the drop off in primary care visits.
Right.
We are dramatically behind on the scheduled vaccines for all of these preventable diseases. What are you seeing? And more importantly, what are you doing to solve that? I mean, since we're not in school, there's not these checks. How are you making sure that we don't have kids falling even further behind?
Absolutely. So one is we're running reports, making sure that we've seen them, because when we see them, we vaccinate at every opportunity. We don't wait for a well visit. If you're due for a vaccine when you're there for foot pain, we're going to give it to you while you're there for foot pain. The other thing we're doing is we're doing telehealth visits, or we're doing what we call hybrid visits. We will do your examination, your history through telehealth, and then we'll see you outside in the tent, and we'll do your physical, and we bring the vaccines out with us, and we'll give them to you in your car for children whose parents do not want them to come into the clinic. But the World Health Organization has said, we're really in a bad place with missed vaccines, and they're very fearful. We were already seeing the highest measles cases in the last 20 years in the United States. Our fear is that those numbers are only going to climb because of missed vaccinations. So we're doing recalls, we're doing reminders, and we're doing hybrid visits.
You're doing a lot of different things in your practice that are novel. Some of them you were doing without the pandemic. You just knew that there needed to be different ways of doing things. So scheduling. It's a challenge for people to schedule visits. It's also something that's kind of hard for a staff to be able to manage. I mean, there's resources that are needed on both ends. What have you guys been doing?
3 years ago now or so, Shauna, that you and I, we had the pleasure of speaking at South by Southwest in Austin, and it was nurse entrepreneurs, right?
Yep.
So the panel before us was Planned Parenthood, and they were talking about the fact that they were using this online scheduling system and that it had really dropped off. There are no shows, that people loved it, and they were finding people were registering at 2 a.m. And so I made a few phone calls, and it happened to be that a colleague that I had known for years and had worked with on a couple of other initiatives, he was doing a startup, and it was called Doc ASAP. And it's an online scheduling system where people could book their own appointments. And I called him and said, I really want to do this. And he said, oh my goodness, we were looking for someone like you. We want to interface with your EHR system. Would you be our beta test site? And the rest is history. We were the first NP-owned clinic in the nation to go with this online scheduling. So people at 2 o'clock in the morning can look at the pictures of the NPs that work alongside me. They can look at the times that the NPs are available in both Amherst and Concord. They can book themselves. It's really a great system. What we also do, though, is when we care plan like that, one of the medical assistants will put on the care plan when the patient's physical is booked, or if they're not booked at all. And we make sure that we schedule before people leave our clinic, so they always have one appointment on the books.
Oh, that's a good way to be thinking about, health is just an ongoing. It shouldn't be episodic. It should be something that is a continual basis. When you think about innovating just in the practice and all of the different ways that you are fundamentally rethinking, making access easier, improving the quality, what are some of the other things in your practice that are distinctive and, you're really proud of?
Our 2 clinics are the first NP-owned clinics in the nation that are NP-led and NP-owned to actually receive federal funding for fellowships. So I have 2 fellowship positions for the next 3 years. So I have 6 NP fellowship positions over a 3-year span. And it really allows me to let them spend days with specialists, to have a graduated patient schedule, and to ease into primary care, and to have mentors that I had to teach me all these great pearls that keep me so excited to take care of patients. So every 2 weeks, I send out Wright & Associates Family Healthcare News Bulletin, and it's where I update what's going on in our clinic, welcoming new providers, what are our latest protocols on COVID, how they can get in touch with us for COVID testing, the latest recommendations on vaccines. This news bulletin that just went out said there's now a recommendation to defer mammograms for 4 to 6 weeks after your COVID vaccine. So those are some of the things that I just, I put those in the newsletter and just as a way to kind of let people know, hey, we're here. And they read it through their portal. We have about 50% of our patients are on the patient portal. So it really goes out to a large percentage of our patients. I also place it up on social media, on our Facebook site, so that patients can take a look at it as well. I think it's just been a way to connect with people, and people come in and they'll say to me, I am so thankful for the communication. I had one woman come in and say, I educated my neighbor on the process for the COVID vaccine because of your newsletter. So I love that because it's doing a service for the community.
Well, the fact that you're sharing it on social media, your ability to care for people outside of, an easy driving geography. I'm curious, like how many people, when they get it, are they forwarding it on to their elderly parent or their college age kid who's trying to figure certain things out? I mean, you're reaching a lot more people than in your own practice.
And probably the biggest reach we had was when the COVID vaccine, it hadn't come out yet, but Dr. Ryan Mallow and I did a 1-hour Zoom interview and presentation on the different vaccines that was shared over 1,000 times. And I put it up on our Facebook site. So there's a lot of ability for very low cost to get a message out, good or bad, right? Good or bad.
Right. Hopefully good.
And the other thing that's so exciting is that for 65 years, nurse practitioners have not been able to sign home health orders. Former President Trump did sign the CARES Act, which took away that requirement that home health be signed by a physician. Up until then, I was paying a physician to sign my home health orders. And so the ability to do that, it takes away a barrier in access to care because people would be delayed in getting their care because I would have to find someone to sign that order. So now all the NPs can do that. And that's so really exciting.
So these are home health orders like getting hospice care, oxygen at home.
Still need a sign order from a physician for hospice care. Although there is a big movement afoot to get rid of that. But this would be if you need a visiting nurse to come into your house because you've just been discharged from the hospital and you have an open wound and you've got some drains in place. I can sign those orders to get someone out to you to have home health care.
Gotcha. Okay. The practice that you're describing and the way you're delivering care to people, I don't think that there's anybody out there who wouldn't want that for themselves, for their children, for the people, that they love and care about. But what is it, when you're describing that, and I'm thinking all these folks who don't have access to this type of care, this type of approach, the nurse practitioner approach, why is this not widely available across the entire country? And more importantly, what do I, as a citizen, as a consumer, as a constituent, as a voter, what do I need to do so that I can have access to this, that we can all have access to this type of option?
Well, I think first and foremost, it's because we have lived in a healthcare model that has been done the same way for hundreds of years. And we have antiquated laws that really restrict the ability to do what I'm doing. I think we're at 24 states now that allow NPs to have full practice authority. And what that means is we're not reliant upon a physician to sign paperwork. And I think what's happened is it's really become a battle in many states. Allow me to work to the fullest extent of my education and training, and I think we would be able to serve patients better. Yeah. So we need to get rid of those antiquated laws.
Yeah. And I raise that because, on this topic of innovating for access, these are truly artificial barriers. We have incredibly well-trained and skilled and experienced nurse practitioners and people at all levels.
And if you look at the statistics, the majority of nurse practitioners train in the communities in which they live or grew up in, and the majority stay in those communities, many of which are rural America.
Yeah, and that's the other part, is that the nurse practitioners have a tendency, and nurses and practitioners of color, they tend to work in communities of color. And so by limiting their ability to have full practice authority, we're once again disadvantaging and creating disparities in access to our most vulnerable and marginalized communities.
Definitely. Yeah. I agree with you.
When you hear the word innovation, what do you think when somebody says that to you?
I think like a lot of people think, that innovation is you have to go out and you have to invent something or create something new. And I don't really think that that's what it needs to be. I think it's seeing something that doesn't exist and changing it up and making it better. I mean, look what nurses have been doing during this entire COVID pandemic. Nursing in terms of IV lines, those aren't anything new, but creating one IV pole with lines to handle multiple patients so that you don't have to go in and out of rooms. That's what innovation is.
And innovation might be using balloons when you don't have access to an incentive spirometer, meeting you in your car to administer your vaccine, having online schedule available at 3 a.m. because that's the best time for you to plan a visit, or dropping off a basket of food, clothing, or medication to your home because that's the care you need and your best access to it. And as Wendy shares, that while people may have access to care, maybe the type of care that they are being given isn't the care they need or the care they deserve. Wendy Wright is a highly energetic, seasoned nurse practitioner who owns and operates Wright & Associates Family Healthcare, 2 full-service primary care clinics led by nurse practitioners in Concord and Amherst, New Hampshire, a state where nurse practitioners are licensed to practice independently, free of direct physician supervision. Her practices employ several other nurse practitioners, registered nurses, and medical assistants. And in addition to diagnosing and treating acute health problems and performing minor procedures, Wendy's team focuses on managing chronic health conditions and offering education and counseling on health promotion, disease prevention, and partnering with patients to make wise and healthy lifestyle choices. Wendy regularly collaborates with physicians and medical specialists, and with the closure of many primary and specialty care practices, she's seen a jump in new patients seeking primary care, and she is committed to providing care to everyone requesting it. With such dire need for primary care providers, Wendy predicts that 20 years from now, nurse practitioners will be the primary care providers for the vast majority of people in the U.S. Access to care. Yep, 3 simple and yet 3 very loaded words with many dimensions that include being comprehensive, affordable, safe, good quality, relevant, timely, conveniently located and available when and where you need them to be, representative, and with the capacity to see all those seeking care. Access to care is vital to promoting health, preventing and managing disease, reducing unnecessary disability and premature death, and securing diagnostic testing, prescription medications, and vaccines. Access to care is not a new issue. But when COVID-19 and the pandemic came crashing upon us, those somewhat hidden elements comprising access to care became glaringly obvious, and the need for innovating to solve them were urgently fast-tracked by the disruptions felt across every facet of the healthcare supply and demand chain that Wendy and her colleagues and the patients and the communities all experienced. And these disruptions have created truly serious medical concerns, Months of sheltering in place and waves of surging COVID cases throughout the last year canceled thousands of scheduled appointments and procedures, shuttered clinics and testing labs, or reduced their hours of operation. And that resulted in steep declines in the number of screenings and preventive and primary and specialty care. Numerous studies indicate that the number of patients screened or given a diagnosis of cancer fell during the early months of the pandemic. Children, by not attending school and missing their well child visits and sports clearance exams, are behind on their vision, dental, and hearing screenings and regularly scheduled vaccinations. The numbers of unvaccinated and undervaccinated children grow each week by alarming levels. For adults, appointments for their preventive care, like eye exams and dental visits, management of chronic conditions like asthma and arthritis and diabetes, screening tests like mammograms and colonoscopies to detect potential cancers were canceled during the stay-at-home orders, possibly leading to undiagnosed malignancies. In some cases, the delay has come at a great cost. Life expectancy, the most basic measure of a population's health, fell by 1 full year in the U.S. during the first 6 months of 2020, and by 2.7 years for America's Black population. That's the largest drop in life expectancy since World War II, and a grim measure of the deadly consequences of the coronavirus pandemic. The stark decline over such a short period is highly unusual and a signal of deep distress. It also reveals a deepening of racial and ethnic disparities. Stunned researchers stated they haven't seen a decline of this magnitude in decades, which is why Wendy and her colleagues are diligently reaching out to patients they've not seen to schedule their care and pleading with their patients. Please don't wait. Don't delay care. Your life depends on it. With thousands of medical practices, hospitals, and care facilities closed or closing, and many nurses and doctors retiring early or leaving practice, and our professional training programs having their graduations delayed, access to care and innovations to address it will be in incredibly high demand and in search of more bold innovators like nurse practitioner Wendy Wright. For See You Now, I'm Shauna Butler. Thanks for listening.
Johnson & Johnson is proud to power up nurse-led innovation that is transforming health outcomes through skill building, leadership development, and more. The American Nurses Association ignites and celebrates nurse-led innovation to redefine quality nursing and advance healthcare for all. Learn more at seeyounowpodcast.com.